$13,432 per person per year. That's what America spends on healthcare. And yet, before we start, this video is informational only. We're not medical professionals, and nothing here is medical or financial advice. Every number you're about to see is sourced from public government and peer-reviewed data. All research comes from the Centers for Medicare and Medicaid Services, the OECD, the World Health Organization, the Kaiser Family Foundation, the Commonwealth Fund, the American Medical Association, and peer-reviewed journals, JAMA, Health Affairs, and the Annals of Internal Medicine. Let's start with the raw numbers. In 2023, the United States spent $4.867 trillion on healthcare. That's 17.6% of gross domestic product, meaning roughly 1 out of every $6 the entire American economy produces goes to the health sector. Per person, that works out to $13,432 per year, using the OECD's comparable methodology. Now look at peer countries. Germany, the next highest spender among large OECD economies, spends $8,011 per person. That's $5,400 less than the US per person per year. Canada spends $6,319. The United Kingdom, $5,493. Japan, just $4,666. The OECD average is $5,829 per capita. The United States spends roughly 2.3 times the OECD average on healthcare every year. The gap versus Germany alone, the closest peer, is about $5,400 per person. Multiplied across 330 million Americans, that's $1.8 trillion in structural premium. Where is that money going? Peer-reviewed research identifies 7 structural drivers. We'll take them one at a time. 1. The middleman chain. A dollar spent on American healthcare routes through 4 to 6 intermediary layers: the employer, the insurance company, the pharmacy benefit manager or PBM, the hospital system, the physician network, and sometimes a third-party administrator. The 3 largest PBMs, CVS, Caremark, Express Scripts, and OptumRx, together handled approximately 79% of all U.S. prescription claims in 2023, according to the Federal Trade Commission. Each layer extracts a margin. 2. Administrative overhead. Himmelstein and Woolhandler, writing in the Annals of Internal Medicine in 2020, estimate U.S. administrative costs at 34% of total health spending versus 17% in Canada. If the United States matched Canadian administrative efficiency, the savings would be approximately $600 billion per year. Billing, coding, prior authorizations, claims denial, and appeals consume enormous staffing at every hospital, clinic, and insurance company. 3. Pharmaceutical pricing. Until the Inflation Reduction Act of 2022, Medicare was legally prohibited from negotiating drug prices at the aggregate level. The RAND Corporation, in a 2024 update, found U.S. brand name drug prices averaged 2.78 to 4.22 times the median price across 32 OECD comparator countries. For insulin, U.S. list prices have been reported at roughly $98 per 10 milliliter vial, versus about $12 in Canada. 4. Hospital consolidation. American Hospital Association data show roughly 67% of U.S. community hospitals now operate within a large health system, up from 53% in 2005. About 90% of U.S. metropolitan statistical areas have hospital markets classified as highly concentrated under Department of Justice thresholds. Cooper, Craig, Gaynor, and Van Reenen, publishing in the Quarterly Journal of Economics in 2019, found hospital prices in monopoly markets run 12 to 26% higher than in markets with 4 or more competitors. 5. Defensive medicine. Malpractice liability exposure drives physicians to order extra tests, images, and procedures to protect against litigation. Mello, Chandra, Gawande, and Studdert estimated the total cost of defensive medicine at approximately $46 billion per year in 2010 dollars, and roughly $60 to $80 billion in 2023. Inflation-adjusted terms, 85% or more of U.S. physicians self-report practicing defensively. according to a British medical journal qualitative study. 6. Limited price transparency. The CMS Hospital Price Transparency Final Rule took effect in January 2021, requiring hospitals to publish standard charges in machine-readable format. Yet PatientRightsAdvocate.org, surveying 2,000 hospitals in July 2024, found only 34% were fully compliant, 3 years after the rule began. Same procedure, negotiated price spreads of 2 to 10 times across hospitals in a single city remain routine. 7. Employer-sponsored insurance. 49% of the non-elderly U.S. population receives coverage through an employer. The 2024 average annual family premium reached $25,572. This employer linkage originates in 1943 wartime wage controls and the 1954 tax code exclusion, making health coverage a tax-free fringe benefit and cementing the employment link. Job loss becomes a coverage loss event for most households. Those are the 7 structural causes. So here's the paradox. The United States spends more on healthcare than any country on earth, more per person, more as a share of GDP, more in absolute dollars. So if Americans are paying the most by a very large margin, are the outcomes the best? We've compiled a free guide, the Healthcare Cost Awareness Guide, breaking down how to read a medical bill, what each charge actually means, and how to negotiate hospital pricing. The link is in the description below. Now the answer to the outcomes question. Life expectancy at birth in the United States is 77.5 years. In Japan, 84.3 years. In Germany, 80.9. In the United Kingdom, 80.4. The OECD average is 80.3 years. The US runs nearly 3 full years below the OECD average for life expectancy, despite spending more than double per capita. Maternal mortality. The United States reports 22.3 deaths per 100,000 live births. In Japan and Germany, that figure is 4.0. In the United Kingdom, 5.5. The US maternal mortality rate is roughly 5 times the peer OECD average and the highest among high-income OECD nations. Infant mortality. 5.6 per 1,000 live births in the United States, 1.8 in Japan, 3.1 in Germany, 3.9 in the UK. Avoidable mortality. Deaths before age 75 from preventable or treatable causes runs at 336 per 100,000 in the United States versus 225 in the peer OECD average. That's about 50% higher. The Commonwealth Fund's 2024 Mirror report ranks the U.S. health system 10th of 10 peer high-income countries across 5 dimensions: access, care process, administrative efficiency, equity, and outcomes. Last place, across all 5 domains. So the paradox is documented. The United States spends roughly 2.3 times the OECD average and posts worse results on every major population health indicator. What does the cost gap actually do to American households? 5 measurable effects. 1. Medical debt and bankruptcy. Himmelstein and colleagues, in the American Journal of Public Health in 2019, reported that approximately 66.5% of U.S. personal bankruptcies involve medical debt or illness-related income loss as a contributing factor. Methodology is debated. Dobkin and colleagues, using narrower causal attribution in the American Economic Review, estimate around 4% of non-elderly bankruptcies are directly caused by hospital admission. Both figures are peer-reviewed. The point holds. Medical debt is a structural economic shock in the U.S. that is essentially absent in peer nations. 2. Uninsured and underinsured populations. Approximately 25.3 million Americans were uninsured in 2023, about 7.6% of the population, per the Kaiser Family Foundation. A further 43 million U.S. adults are classified as underinsured, meaning out-of-pocket health care costs plus deductibles exceed 10% of household income, per the Commonwealth Fund 2024 Biennial Health Insurance Survey. Together, roughly 70 million Americans cannot reliably afford to use the insurance they technically have. 3. Surprise billing and price shock. The same MRI scan can cost $200 at one hospital and $2,000 at another, in the same city for the same patient. A ground ambulance transport generates charges between $940 and $1,800 on average. Before the No Surprises Act took effect in 2022, about 1 in 4 insured ambulance rides resulted in a surprise out-of-network bill. Hospital same DRG price spreads of 2 to 10 times across facilities in a single metropolitan area are routinely documented in the disclosed transparency data. 4. Care rationing by cost. The Commonwealth Fund's 2024 survey found approximately 1 in 3 U.S. adults skipped or delayed needed medical care due to cost in the past year. That includes filling prescriptions, seeing a doctor when sick, scheduling recommended tests, and following up on chronic conditions. Medication non-adherence due to cost is the single largest adherence risk factor measured. 5. Job-locked coverage. 49% of non-elderly Americans receive their health insurance through an employer. When a job ends, so does the insurance, unless the worker pays COBRA continuation premiums, which average $703 a month for individual coverage and $1,997 for family coverage. Job transitions, entrepreneurship, early retirement, and caregiving sabbaticals all collide with this coverage gap. Economists describe the resulting friction as job lock. Those are the 5 real-world effects, documented, measurable, peer-reviewed. Let's bring the picture together. The United States spends more on healthcare per person and as a share of GDP than any country in the world, roughly 2.3 times the OECD average. Outcomes rank last of 10 peer high-income nations on the Commonwealth Fund's mirror framework. 7 structural drivers: layered middlemen, administrative overhead, pharmaceutical pricing without aggregate negotiation, hospital consolidation, defensive medicine, limited price transparency, and employer-tied coverage account for the cost gap. None of these are individual consumer decisions. They are system-level features that have compounded across decades. Reform is underway. Medicare's drug price negotiation program announced its first 10 negotiated prices in August 2024, effective in 2026. Hospital price transparency and insurance transparency rules are slowly producing usable pricing data. Debates over single-payer systems, a public option, and direct primary care continue at both federal and state levels. But the paradox, highest spending, worst peer outcomes, remains the defining fact of American healthcare in 2026. You shouldn't have to go broke to feel whole.